We will now talk about the renal involvement in sarcoidosis. Renal involvement seen in less than 5% cases. There is nephritis, and renal failure is more commonly due to hypercalcemia rather than nephritis. Now, nervous system. Any part of the CNS and PNS can be involved. MRI shows presence of space occupying lesion. That is granulomas. MRI may not show anything due to small lesions. Then CSF may show lymphocytic meningitis. With mild increase in the protein. Though any part of the CNS can be involved, there is predilection for certain areas. More commonly involved areas in the CNS include cranial nerve. Seventh cranial nerve can lead to facial paralysis, which may be mistaken for Bell's palsy. Then there may be basilar meningitis. Then can lead to myelopathy. Anterior hypothalamic involvement can be there. Anterior hypothalamic involvement. Then there can be cognitive dysfunction. Seizure. So these are the CNS manifestation. The lesions on MRI, they may at times mimic the multiple sclerosis also. So multiple white matter abnormalities seen on MRI, they can mimic the lesions of multiple sclerosis. But the lesions in neurosarcoidosis shows meningeal enhancement. Then anterior hypothalamic involvement will support sarcoidosis. Then extra neurologic features of sarcoidosis. This will also support the sarcoidosis. Now let us talk about the cardiac diseases. There can be congestive cardiac failure, can be arrhythmia, due to granuloma. Ventricular tachycardia in cardiac involvement can lead to sudden death. There can be musculoskeletal involvement also. Then, rarely, it can also involve breast, testes, ovary, or stomach. But the involvement is not very common, and biopsy must be taken to rule out cancer. We will now talk about the lab findings. Specific organ involvement can be diagnosed by using imaging like chest X-ray, MRI of various organ and PET scan. Then biopsy may be necessary to determine the cause of the radiologic abnormality that is seen on the imaging. Then serum ACE level having low sensitivity and low specificity. So it is generally more than 2 times increased, more than 50% increased in sarcoidosis. But it is not specific for sarcoidosis. Mild increase may also be seen in diabetes, and more than 50% rise is seen in leprosy, Gaucher's disease, hyperthyroidism, and disseminated granulomatous infection. Disseminated granulomatous infection like miliary TB. We will now talk about the diagnosis. If a patient is referred for possible sarcoidosis, biopsy of the possible granuloma should be done, and if there is no alternative diagnosis, then diagnosis of sarcoidosis can be made. If there are features suggesting sarcoidosis, like X-ray showing adenopathy, lupus pernio, erythema nodosum, maculopapular rash, uveitis, optic neuritis, seventh nerve paralysis, etc. Then biopsy should be taken if possible, or a needle aspiration should be done. If granuloma is present with no alternative diagnosis, diagnosis of sarcoidosis is made. Then granuloma is not seen in case there is no granuloma plus no alternative diagnosis. Then serum is more than 2 times upper limit of normal. Bronchoalveolar lavage lymphocytes more than 2 times upper limit. If present, can be sarcoidosis, and if not present, can still be possible sarcoidosis and may be followed up. Now we will talk about the management. So we will divide the management to acute disease and chronic disease. So acute disease with minimal to no symptom. If abnormalities of cardiac, ocular, or calcium metabolism or any other threatening abnormality is present, then a systemic therapy should be started. If there is no involvement, no therapy is required and patient may be followed up, and it may resolve with time. There is single organ involvement. Topical steroid can be tried. Like for ocular involvement, ocular eye drops can be used. If it is not a single organ involvement, we obviously have to go for systemic therapy. Then if multiple organs are involved, then definitely systemic therapy with glucocorticoids is needed. And tapering of the glucocorticoids to less than 10 milligram in less than 6 month time is planned. And if the steroids can't be tapered, then consideration for any alternate therapy is needed, and we can go for methotrexate, HCQS, or azathioprine. We have discussed the management of acute disease. Now we will see the management of chronic sarcoidosis. In chronic sarcoidosis, diagnosis has already been made and patient is using glucocorticoid. If glucocorticoids they are tolerated and those can be tapered to less than 10 milligram per day, we can continue with it. And if no, should seek alternative agent. Similarly, if glucocorticoids are not tolerated, we should again go for alternative agents, including methotrexate, HCQS, azathioprine, leflunomide, mycophenolate, and minocycline. In case glucocorticoids are not effective and alternative agents, they are also not effective, when tried they are also not effective, then one can go for other agents like infliximab, cyclophosphamide, thalidomide. So these agents can be used for the management. So this was about the sarcoidosis.